When it comes to like seeing and treating patients with neuroendocrine tumor, I do feel that as a GI medical oncologist, if we see other cancer like colon cancer, cholangiocarcinoma, pancreatic cancer, the first thing that we're going to do when we see a patient is like do an NGS, right? We do like NGS, both blood and tissue for the majority of other GI malignancies. In your practice, in the patients who come to see you with newly diagnosed metastatic, well-differentiated grade 1, grade 2, grade 3 neuroendocrine tumor, what is your approach on the NGS testing? Do you usually do it? If so, do you usually do tissue, ctDNA, blood, or both?
We usually do tissue, and we do it. So oftentimes it wouldn't change our initial management, but we do it sometimes more for academic reasons to help better understand. But every now and then we do find actionable alterations.
What are the alterations that you find that has been helpful?
We found high tumor mutation burden. We found mismatch repair deficiency. Sometimes after the tumor has been exposed to a lot of different treatments, and sometimes we see some fusions that are targetable.
Interesting. How about you, Rob?
Yeah, pretty uncommon to pick up anything actionable. Every now and again, we will find something. We do it. It's not as crucial to do upfront as in some of the other malignancies. So I don't see other GI malignancies, but I see thoracic malignancies, and certainly it's crucial for that population. But it really doesn't change the upfront management for what we do.
Right, exactly. I feel the same way. I would say, I don't know if you feel the same way. I even have a lot of, especially when it comes to well-differentiated low-grade neuroendocrine tumor, like grade 1 KSA7 less than 3%. Even when they have widely metastatic disease, when I check a ctDNA, a lot of times it's negative. So then, like, is it because we cannot find out circulating tumor DNA when they have widely metastatic disease? I don't know if that's been your experience as well.
Yeah, I haven't used ctDNA that often in neuroendocrine.
You'll likely find an MEN1 in there, but it's pretty much the extent of, what you'll see. I think it's more crucial to work, make sure you have your imaging done, your multidisciplinary team, your pathology review, have all of that in place, rather than waiting on molecular testing.
Exactly. That's definitely a completely different approach compared to, like, say, thoracic oncology or like pancreatic adenocarcinoma. And I also feel that maybe because of the location, a lot of times I would say if it's more aggressive tumor, say higher grade 2 or grade 3 neuroendocrine tumor, I kind of feel that there's a higher chance that I can pick up something, say VHL or CHEK2 or sometimes like ATM and BRCA. And a lot of times we can also pick up germline BRCA mutation or ATM mutation. And of course, that will help us, like when we consider chemo in the future, what will be a better chemo or PARP inhibitor, things like that. But definitely not like changing our management when we first start seeing a patient. Then it comes down to management. A newly diagnosed metastatic well-differentiated grade 1 or grade 2 neuroendocrine tumor, how do you decide between active surveillance versus starting them on a somatostatin analog?
Yeah, that's a good question, because there's definitely a group of patients who would be appropriate for surveillance without treatment. Generally, we think about, how the patient is, their comorbidities, their age, and what their natural prognosis would be, right? Because if the neuroendocrine tumor is the least of their problems, starting treatment can actually lead to side effects and, time burden, financial burden, and things like that.
Yeah, I agree. I think not everybody needs treatment started right away. One of the big things I look at is to see if the patient has had prior imaging. And so many times we can find something. I see a lot of lung nets. And so sometimes these patients come in with lung nodules, and we get a biopsy and it shows a low-grade neuroendocrine tumor. They're completely asymptomatic, and they tell me, oh yes, I had a scan done 5 years ago for a kidney stone. And so we'll track down that scan, and sometimes we'll see that nodule that was there. Those are the patients that we can watch comfortably and say, all right, well, we know you have this cancer, but it's not doing anything, and it's something we can watch, and maybe you won't ever need anything for this. But similarly, if patients, again, have low burden of disease, are asymptomatic, especially the grade 1 tumors, maybe they've had their primary tumor taken out already and they have a few residual nodal metastases that are picked up on a dotatate after the fact. Sometimes you don't need to go back in and try to get everything. You say, all right, well, this is where we're at, and you just watch closely.
So for a lot of patients with stage 4, widely metastatic neuroendocrine tumor, like they are symptomatic or it's heavy tumor burden, usually our general approach would be we start patient on a somatostatin analog, right? And then we probably just do restaging scan every few months and then wait until the cancer progress. However, we do have the NET-2 trial showing that in patients with advanced higher grade, like case 7 greater than 10%, or grade 3 neuroendocrine tumor, they found out that first-line PRT improved progression-free survival compared to high-dose octreotide. So we do have those data.